Good afternoon, and we are here to talk to you about using machine learning and secondary care activity data for early diagnosis of cancer. I am Divya Balasubramanian, Principal Data Scientist in the Central Data Science team in NHS England, and this is Hadi Modarres, Senior Data Scientist in the same team. And this is a joint project with between the Central Data Science team, the Strategic Analysis team, as well as the Cancer Program in NHS England. So just a little bit about our team. So this is a fairly new team after the merger between NHS England X and Digital. And we are about between 30 and 40 members of staff in this team. And we do a number of different types of projects within our team, including predictive analysis, NLP, a lot of AI and ML are what you'll hear about in our work. And there's also a lot of research and emerging tech that we look into. But I'm not going to go into too much detail, but if you would like to know more about our team, please check out our website and the QR codes on the slide. And this is, as I mentioned, a joint project with the strategic analysis team. This team is also about 30 people in the team, and they work as an in-house consultancy on a number of areas of work. They are primarily project-based and work across strategic and cross-cutting work, which are demand-led. And in fact, there is another talk running parallelly in a different room, so you may want to catch that on the recording at a later time if you would like. And also proactive and horizon scanning work that they do. So jumping straight into what this project is about, as Ruth and team mentioned previously, the NHS long-term plan is to increase the number of cancers who are diagnosed early on, in the early stages. And we found that late-stage diagnosis has often been we know that late-stage diagnosis is often associated with fewer treatment options and poorer outcomes for patients. And we are currently not able to identify all the subpopulations at higher risks of diagnosis of some cancer for some specific cancer sites. And we have found that new machine learning methods are available to identify patients at risk and have been used in different countries like the US. So we have recently strengthened our data science capabilities within NHS England, and we are looking to apply some of these methodologies in this context. So we are also looking to leverage on the more patient-level linked data sets that are now available within the organization. And this work has been commissioned by the Cancer Program in NHS England. So the question we are looking to answer through this project is, can we identify the characteristics of cohorts of patients who are at risk of presenting with cancer within a few months or years, and with specific focus on the priority cancers, and also in terms of identifying the patient's interactions with the healthcare system. We have been provided nine specific priority cancers by our stakeholders, which are the Cancer Program, and we will be talking to you now about how we went about with this approach. I'm now handing over to Hadi to talk to you about the data and methods.
So as part of this project, we created a comprehensive patient-level data set at national level, which combined a number of different source data sets, which went through a process of data cleaning and feature engineering. So we worked with the Master Patient Index and the Bridges to Health segmentation data set to create some demographic and socioeconomic variables such as age, measures of deprivation, gender, and some geographical variables as well. Then we used the SUS data sets, the secondary use data sets, to identify diagnoses of patients and the interactions that they had with the healthcare system. So for example, the number of attendances that they had at A&E or the number of inpatient appointments that they had. And we also had access to 111 data, and from that we could extract features relating to the symptoms that people had called about and the number of calls that they had made. And we used some clinicians' inputs to try to identify which of these symptoms might be cancer-related. And we also had access to ONS mortality as well. And then what we did from these derived data sets and all of these derived variables, we combined them together to curate our modeling data set. So to show you what the patient pathway looks like from our data set, we used 5 years worth of patient history to create these features. And then we looked to predict if individuals would develop cancer up to 2 years ahead. For most of our analyses, we focus on trying to predict the cancer looking 1 year ahead, so 52 weeks ahead. And here you can see across these 5 years, we might be identifying patients who attend an A&E setting, who have a diagnosis made at the inpatient setting, and who may later call with 111 and to report some symptoms. And then looking up to 2 years ahead, we see if this patient did go on to develop cancer or not. Of course, what's missing from this data set and what we hope to add is like primary care interactions as well. So overall, we curated this data set focusing on the age range of 40 to 74, which is the age range that the cancer program wanted to focus on, and leading to a data set of 24 million patients. So in terms of our methods, we used a machine learning approach where we took this data set and we split it into a training and testing data sets. We trained a model to try to predict the risk of cancer on the training data set. We experimented with a number of different types of machine learning model, and we identified the gradient boosted trees as the one that was best performing. And then what we did was we took this model, which we created different models for different cancer sites, and then we tested its performance on the holdout data set, which the model had not seen before. And then we obtained individual patient level risk predictions to obtain model performance values, such as the sensitivity and the specificity of the model. Of course, our aim overall was to identify high-risk cohorts. So our approach to do that was to look at the risk scores from the model and to identify those who have the highest risk scores, and then look at those individuals and try to describe what are the characteristics of these high-risk groups. So this slide is essentially to show the structure of our code base, and to mention that we try to modularize our code as much as possible, and we aimed for a kind of silver level in reproducible analytical pipelines. Our data sets were coming from the National Data Platform in Foundry, and we also used the NHS England Unified Data Access Layer platform for our modeling. So in terms of the preliminary results from our analyses, across all cancers in our data set, we had about 154,000 new cancer diagnoses made in the next year, and this represents an incidence rate of about 1 in 170. For a specific cancer type, so if we focus on bladder cancer, the incidence rate is about 1 in 4,000. So there's a big imbalance between the cancer cases and the non-cancer cases. So for our machine learning approach, when we're training our model, we used a sampling technique to balance this data set in order to train our model. And here you can see the number of instances per different tumor site for different cancers. So if we look at the model performance, here we're showing the area under the curve, the sensitivity and the specificity for the models that we created on the testing data set. So the area under the curve values, they range between 0.74 to 0.85, and this does vary by cancer type, depending on kind of the symptoms that are present. Some cancer sites may be easier to predict and some more difficult. But the performance values that we obtained are consistent with what we see in literature. when using machine learning techniques to predict cancer. What we wanted to do is to get to the cohorts, to identify the characteristics of these high-risk cohorts. So if we take the example of bladder cancer, imagine that we've trained this model and now we're testing it on this holdout test data set. And for each ID, each individual in the data set, we have a model risk or a prediction from the model as to whether this individual will develop bladder cancer in the next year or not. Then alongside that, there is the true label, which is if they actually did develop bladder cancer or not. So if we apply different threshold values, we can create different cohorts. So if we have a threshold value of 0.5, for example, then all of the IDs in this table will be included in that cohort, excluding ID 1 and ID 3. But if we have a higher threshold, so for example, if we picked a threshold of 0.9, then only ID 4 would be included in that high-risk cohort. So if we plot this for bladder cancer, what we're doing here is we're showing on the x-axis the cohort size that's created, and we're scanning through different threshold values, starting from 0.5 in the bottom right, going all the way to 0.95 in the top left. And on the y-axis, we have this lift value, and the lift value is indicating the ratio of bladder cancer cases in this cohort relative to what's found in the general population. So the trend that we see is that as we increase the threshold value, the size of the cohort reduces, and at the same time, the cancer rate within that population increases. So if we, for example, looked at a threshold of 0.9, then this leads to a cohort size of 280,000 people with a cancer rate of 1 in 380. And this is in comparison to a cancer rate of about 1 in 4,000 if you did screening across the whole population. So if we look at different cancer types and you look at the high-risk groups and what the cancer rate is within those high-risk groups compared to the overall population, you can see that within the high-risk group, there is about 7 to 8 times higher cancer rate. So I'll hand over to Divya to discuss the explainability of the results.
So we've created these high-risk groups. Now we are going to identify what are the features that helped us to identify these high-risk groups. Why did the model select these kind of patients as high risk? Based on what features has it done that? So we use the XGBoost feature importance, which is calculated based on the variable gain that identifies features that are most important for the model outcome. And we applied SHAP on it to identify the direction in which the model outcome has been affected. So how you would read this chart, for example, is higher the age, there is a higher risk of someone presenting with cancer. More 111 cancer-related calls also has higher risk. And we also included geography in our features. And so here in this particular case, it shows that South Yorkshire and Bassetlaw Cancer Alliance has a lower risk. So we have these features now, which we have broadly bucketed into 3 different broad categories. Some of the demographic features, for example, include the age, which is the most prominent feature, as you would normally expect, with a mean of about 65 in bladder cancer cases compared to 55 in general population. And we found that about 76% of male, we had about 76% of male patients in the bladder cancer group compared to the general population, which had 50%. And in terms of geography, we found that Devon ICB, for example, had 40% higher bladder cancer incidence. We also found that interactions with the healthcare system were significantly impacting the model outcome. Calls to 111 reporting cancer-related symptoms in the previous year were about 3.2 times more common in the high-risk bladder cancer group compared to the general population. And also calls reporting blood and urine in the previous year was 46 times more likely in the bladder cancer group. And finally, if you included comorbidities or other diagnoses, COPD diagnosis was 4.2 times more common in this high-risk group, whilst also diagnosis of diseases in the urinary system in the last 5 years was about 4.3 times more prominent in the high-risk group. So we found all these features, how do you actually go about actioning this, and what are some of the ways in which you can make this into an actionable insight? So this is an example of how a case finding could potentially look like. So if you took the whole population, we have about 24 cases per 100,000, and then you start adding some of these filters that you've gathered from the previous slides where we have looked into the top features that have influenced the model outcome. So you start adding the high-risk region, higher risk of demographic, a risk symptom like call with cancer symptom to 111, and finally a comorbidity like previous diagnosis of diseases in the urinary system. You start noticing that the number of cases per 100,000 start increasing, and the incidence of cancer will also increase significantly in these groups because you're narrowing the cohort into something sizable. So this is one of the examples in which we think that the outcomes of this model can be utilized. So in terms of preliminary conclusions from this work, the project's machine learning model performance on the curated data asset is comparable with models that have been used in literature. We have found that most literature have used deep learning models, which are not explainable, but we have tried to make sure that we use an explainable model so this can be translated into something that's actionable. So explainability and evaluation metrics can be used to identify important features that identify characteristics of cohorts at risk, as well as 111 calls with cancer-related symptoms provide strong signals to predict high-risk cohorts. In terms of next steps, we are looking to include primary care data into our integrated data asset. Our preferred option is Open Safely, but unfortunately, it's not available until January 2025. So we are going to work on a local use case, which is Leeds Data Mart. We have been given some honorary contracts kindly by the Leeds Council, where we are going to be working on their primary care data and experimenting to the integration of primary care into a data asset similar to what we have created so far. And we are also looking to introduce prescription data into our data asset. This is at the national level that we have built so far. We have received intelligence from local trusts who have built similar models on very specific types of cancer and on very specific local data that drug data tends to provide strong signals towards early diagnosis of cancer. So we are looking to see if that is applicable in the national context as well. And finally, we are liaising with clinicians to verify our outputs and improve the models for specific cancer types. With that, we'd like to open for any questions. Thank you very much.
Thank you, Hadi. Divya, fantastic talk with 2 minutes to spare. Such a lot of information to cram in and still have 2 minutes over. We've got lots of questions coming through on the Slido. So just to remind people who haven't got access, you can ask questions on slido.com. The code is 3716942. And I'm going to look at the questions. So first up, Richard asks, how many patients were lost due to data cleaning?
So in terms of data cleaning, well, we filtered by age. So you saw we filtered the age to 40 to 74. Our only other criteria to include patients was to make sure that they had a valid age, and that was well over 99% of the data. I think there were very, very few cases where there were patients with no age whatsoever. So we tried to include everyone in the model. Where we had missing data, then we tried to account for that in our feature engineering. So for example, if they were missing a categorical value like geography, then we created a variable to account that this information is missing for this patient, and that was included in the model.
Okay, thank you very much. Adam Hollings asks, which sampling method did you use to address class imbalance?
We used undersampling in this particular case because we had really less number of samples with cancer. We were testing oversampling as well. However, the model outcome was not particularly credible. And so we stuck with undersampling, which seemed to be working better for this use case.
Thank you. Now, Nicola asks quite a long question, so bear with me. Is there a risk that you're basing too much on dependence characteristics, i.e. it is not living in Devon, ICB, that increases risk, it's the age that influences the risk, and more elderly people live in Devon? Might population scaling help?
Yeah, absolutely. We anticipated this could be a possible question, primarily because this does not suggest that we are going to be applying the model only on Devon, for example. This is suggestive of how certain characteristics, which may be in collaboration with the fact that they are based in Devon, could help to narrow down the population into something sizable that can be, who can then be sent either for screening or if can be contacted for awareness programs and so on. We do expect that the geography variable will help us to firstly gather intelligence about like why are certain ICBs tending to be highlighted by the model, and in which case it'll help us to also identify other certain types of population in that particular location that are tending to have more cancer diagnosis, and can we actually look into possible inequalities that could be prevalent in the rest of the country as well. Do you want to add anything?
No, I think, yeah, Divya covered it all. And we see that as a potential for having like customized screening by geography. So each different geography could have its most important characteristics included for any screening or targeted case finding.
Yeah, and so interesting the result you get with 111, and it really shows the sort of the value and the importance of being able to have some sort of primary care data in there, the value that adds. Okay, I'm aware that we have lots of people in the room who may not have managed to access Slido, so I will pause quickly to see if there are any questions in the room before returning to Slido. Right at the back. Okay, here we come.
Thank you. Really cool stuff. Just following up on the last question a bit. So the translation of the SHAP values into a kind of cohorting model seems really challenging to me, in the sense that you're representing real biological risk, kind of collinear risk of all of the other stuff that's wrapped up, and bias, most importantly. So I guess when you're doing it, how do you make sure that you don't end up amplifying existing inequalities by just cohorting people who are best able to get diagnoses rather than kind of that true risk?
Thank you. Very interesting question. So we have been verifying these outputs with clinicians. We are working closely with a clinical fellow who has been referred from the cancer program to us. And throughout, from the start, we have been working closely with clinicians to identify the features that go into our model in the first place. So when we got the list of 111 features and all of the symptoms that patients had called 111 with, we worked with clinicians to identify which ones can be cancer-related and which ones aren't. So these have helped us to narrow down the features. The feature space is really large, and there is definitely bias, I'm sure. This is very much preliminary results, but some of the ways in which we're tackling this is by working closely with clinicians to make sure that the model isn't making an arbitrary outcome that we are suggesting is definitely the case, but actually verifying this with credible sources such as them.
Okay, thank you. Another question from Slido, this time from someone anonymous, asking, increasing the threshold would eventually increase the true positive rate. However, there's a possibility of the higher false negatives. How would you handle this situation?
Yeah, it's a very valid point. I think it depends on the application. So we envisage that, let's say, working with a cancer program for different cancer sites, there could be different types of intervention, different types of screening program, and kind of would seek their input on what would be a reasonable cohort size and that would be suitable for that intervention that they have in mind. So the threshold is a parameter that we can adjust to create different size cohorts which matches up with the potential intervention that would be possible for that population size. So that's how we would try to adjust for it.
Thank you. Amy asks my favourite question to ask at these types of things. Is your code and work available?
Not yet, but it's definitely in the pipeline. We are looking to work with some specialists in our team who are very good at publishing their code to make sure that we make this available in a format that doesn't compromise on any privacy that we shouldn't.
And without wanting to plug our website further, where might that be available, Divya?
In the website. Hopefully you've got the QR code to our website. If not, please do reach out to us after this talk. We'll be more than happy to share it with you. Thank you.
Brilliant, thank you. Back to the questions on Slido. Amy also asks, you mentioned verifying predictor variables using literature. Are there other ways to ensure variables have a causal relationship and it's not just chance?
So I would say what the point that Divya mentioned in terms of discussing with clinical colleagues is important here. So we verify our outputs with clinicians. But there's also some analytical techniques to try to look at if these variables have a causal relationship with the output. So those are things that would also look to explore as well.
Thank you very much. We've got a few more lined up on Slido, but I will pause again to check if there's anybody in the room who wants to put their hand up at this point. If not, back to the Slido. They are piling up. Jess asks that you've mentioned the next steps are to sort of verify this with clinicians, but what are your plans to operationalise this?
So the steer we've received from the cancer program is that there's a possibility to apply some of these outputs by making this potentially a screening program or for case finding or for awareness programs. It isn't finalized at this point. However, that is the direction we're headed towards, provided we are able to include primary care data into our data set. So most of the cancers that have been listed can also have vague symptoms, is what we've been told. So you can't nail it down using just the features that we have. So it will be alongside local intelligence that it will be operationalized. However, the aim is for the programs that I mentioned earlier on.
Thank you very much. You'll be glad to know I'm going to ask you 2 more questions and then this grilling will be over. Jess asked that you mentioned, oh no, sorry, I already asked that one. Peter asks, was it a conscientious decision not to use the monthly cancer submissions data to derive your cohort? The CWT cancer waiting times, sort of the national kind of aggregate data collections that come in. Presumably because they weren't patient level. Sorry to answer the question there.
Yeah, exactly. Because we had access to patient level data. So all of our feature construction, all of our feature engineering was to create these variables at patient level. And then we went from the patient level model results and then aggregated to describe these cohorts.
Okay, thank you. And the last question goes to Kathy. Do you think these insights might be useful in the future to co-design bespoke prevention and promotion campaigns with specific populations and cohorts of patients? That is a very good question to end on, I think.
Yeah, absolutely. So one of the segue into a different kind of product we were looking to build also was a dashboard off the back of this data asset, and we've done some user research sessions with clinicians across several ICBs as well on potential for usage of this dashboard, and that was for identifying zoning into specific populations and potentially looking at different characteristics of those different geographies or other filters that they can possibly use to be able to use this for a wider use case rather than only for rather than only the screening programs that we were originally suggesting for the cancer program.
Absolutely. All this work needs to be used as many times as possible, I think it's fair to say. So one last time, just thank you to Hadi and Divya.